I'm going to go back to the same challenge that we actually faced in regard to the local therapy. Now we have a patient started on sorafenib. Dose probably was ongoing at 400 milligrams twice daily, doing very well. Maybe at some point, some grade 1 hand-foot syndrome, hold the drug for a week, restarted at the same dose, and maybe later on, maybe 400 milligrams daily simply because of further grade 2 hand-foot syndrome. But patient doing well, CAT scans repeating themselves. And we look at the scan, and we're going to see a little bit of more of that stable disease or maybe a little bit of growth, and patient is not necessarily happy. They like to see tumor shrinkage. So I'm going to go back to Riccardo, and from his perspective, as an interventional radiologist and as a radiologist, how do you assess sorafenib response? You had experience with this case study and many others. Like, how do you assess that? How can I assure the patient you're doing okay?
Well, I think the first thing is that you really need an expert radiologist in assessing those scans, because interpreting HCC in cirrhosis in patients receiving different forms of therapy is now like the kind of bread and butter for any general radiologist. So the first thing is to make sure that even the diagnostic radiologist is in the loop of the liver tumor board, is engaged in this. Having said that, we do not really aim with sorafenib for any shrinkage of the tumor or any response in the classic term. There are responses. There are objective responses that have been measured. Some series have reported up to 10, 20% of responders, but that's not really the goal of the therapy. I would say that the stable disease, I mean, the lack of progression is what you typically consider as a sign that the treatment is efficacious, although there are studies that suggest that even in front of progression, not all progression are the same, and patient may still have some benefit from sorafenib even beyond progression. Actually, in some of the studies, like the SHOP trial, treatment was continued beyond radiological progression. So this is an open question. I think as radiologists, we can provide a fair assessment of response, recognizing the limitation of imaging in this area. I would say that probably there will be this will be truly an area for more and more investigation. We still use alpha-fetoprotein. I mean, I already mentioned before. I was expecting the hepatologist to be more, supportive of the alpha-fetoprotein, but this was somewhat
well, in all fairness, it was for screening purposes,
yeah,
but anyway.
For screening, but I mean, it's not that, again, you really have like a cutoff or a percentage decrease that you would consider as the target, but again, it's the comprehensive assessment of the patient. In that context, having, let's say, information from radiological imaging and alpha-fetoprotein combined can, tell you how the patient is doing. Of course, as we discussed before, given that sorafenib is the only approved treatment for HCC at this point of time, this question is applying less pressure on the clinician than if it would be with more drugs available. I'm speaking about you guys.
Absolutely. Well, if anything, please listen very carefully to what Dr. Lencioni said. This is very, very important. If you recall, when you go into the clinic and you're going to look at the patient, you're going to look at them in the eyes, you're going to examine them, you're going to be able to tell if they're doing well or not. That's a very critical component to see if patients are doing well on sorafenib or not. If anything, it was a component of the treatment on the SHARP trial. The CAT scan as well, please look for yourself. This CAT scan can be very revealing, and if anything, talk to your radiologist, explain to them what form of therapy you're applying here. This is an anti-angiogenic therapy. This class of drug has shown in multiple sites and multiple diseases that it can cause some form of quote-unquote necrosis, i.e. the tumor might still be there, might even increase a little bit in size, as we heard from Riccardo, but still the treatment effect is over here. So it's very critical that you put all of this collectively with the alpha-fetoprotein. It has never been validated, obviously, in regard to to being a tumor marker, but nonetheless, in a specification, it might have value. Collect that information together to decide if this is the right treatment to go on the patient. With the lack of second-line therapies, except for clinical trials, sometimes we have to err on the cautious side and accept that the patient might continue on therapy despite some progression, because clinically they're doing well until we have further confirmation. With this said, I would like to move on to really a very important part of the discussion, which is really what we'll cover the next 15 minutes or so, which is really where the future is going. I have to admit that